Good afternoon, each one of you. I'm Dr. BINIRAJ KR, the Program Director for your All About Implants Convention to be held on 10th and 11th this Saturday and Sunday. This program was actually not a prefixed one, and here it is being presented as a gift to the beginners of implant program, especially for those delegates who are not so much used to placing implant or not have undergone similar programs like basic implantology prior to this convention. So this program is basically designed for the beginners, not the ones who have already placed at least one implant. Because that was a necessity, because I was getting so many calls from so many delegates, especially the interns and postgraduates and few of the specialists and practitioners also, asking whether there's going to be an advanced program of implantology or IBT going to teach us something basics also. So this idea came up out of this apprehension. Because this program is named as All About Implants, and it has been publicized as a program which will be covering everything from basics to the advancement of implantology presently in probably at least what is practiced in our country. So today, this program is designed to give an overview of what are the basic things that you require to start your implant practice, and what are the basic procedures you should be knowing, or rather you should be revising in between, so that you can continue practicing implant even after a short break in your career in implantology, because implantology is not practiced in at least our part of the country as an everyday dental procedures like the restorations or other procedures you do. So it is basically a natural phenomenon that you tend to forget the steps which are being taught in such courses, because these implantology courses are not taught as a regular syllabus in dental curriculum. So we are planning such a program here, which will introduce you to dentistry, the implant side of dentistry. And moreover, if you can have a recorded video of this, it will help you to revise this procedure whenever you get a patient which probably you're not done in nearby future. For example, you might have been placing implants, but for a gap of 2-3 months or years together, you never got a chance to do one. So next time when you start off a case, or when you're planning a case, you might require such kind of a guidance. So we are giving you a step-by-step procedure which you can use as a guidance whenever you practice implantology, especially not at a very frequent interval period. So let me introduce the things what you require for an implant placement first, and then we'll be going into the procedure of how to go about with the prosthesis aspect of it, especially the impression and other trials and crown fixing procedures. So to start an implantology practice, you would require such kind of a motor, which is called as a physio dispenser. This physio dispenser is nothing but something very similar to micromotor, but it has got a speed variable which is much very much of a range than the normal micromotor. So here you can see a speed range being kept as 1000, which is possible in a physio dispenser, along with a torque that is being graded here as 45 Newton. So what happens here is, it's not just the rotation that is delivered through this equipment. You can have a torquing force also, which is definitely required when you're placing an implant thoroughly, pressurely into the bone. So you would require a torque also, not just the speed. So this equipment deals with that. And in addition to that, it has got a saline fixed to it, which will continuously being jetted out through the tip of this handpiece. You can see this handpiece wherein the tip of the saline injector is connected. So there will be an injecting saline from this side. Plus, this machine has got a torquing facility, and the speed can be controlled to any level. Because this speed, what you see here, is normally the speed required for a drill. It is not the speed that is required for an implant to be placed inside the bone. It is much, much lesser. So all those kind of variations can be dealt here. And you have these digital screens which will help you to change the amount of coolant or the saline to be ejected here. It's from 0% because you don't need a saline ejection during an implant placement, but you definitely require quite a good amount of saline in the process of implant drilling, especially in a very harder, denser bone. So according to that, you can vary the amount of saline being ejected through the tip of this handpiece. So these are the basic instrument you require for physio dispenser as such. I mean, the components of physio dispenser. And you have an implant kit here. This is an implant kit of GMI Frontier Company, which has got a series of drills, which ranges from a lance drill, a pilot drill, then different drills, which ranges between the diameter of 2.8 to 5.10. So you've got different diameters of drills here. This is to expand the orifice or the entire osteotomy site of the preparation which you're doing. Similarly, you have got a series of countersink drills also here. So drills in this particular kit, this is a basic kit. You got much better, bigger, larger size, larger number of components to be added to this, which will make it a bigger kit. But this kind of a kit is sufficient for a beginner, which has got this series of drills and a series of countersink drills also. These drills, as so it is supplied by GMI company, has got different length markings, not the length as such, but markings of length, which varies from 6.5, 8, 10, 11.5, 13, 15, 16. So it has got different ranges of markings on the same drill, so that as we go deeper into the bone, you will be definitely going deeper 1 millimeter or 0.5 millimeter or 1.5 millimeter as it is marked here. So these kind of drills, all these drills has got the same kind of markings ranging from 6 or 6.5, whatever the company says, up till 16 or 17. And the drill may be having a different kind of markings on it. I mean, the company might give you a different marking on it. So some companies give same 8 millimeter of different diameter, 8 millimeter length of different diameters. So that's another kind of drilling sequence what that company gives. And now here, when it comes to countersink drills, this has got a cutting edge only on the top portion of the drill. The down portion or the root-shaped tip of the drills doesn't have a cutting edge here. So this basically is meant to expand the orifice area, or rather to cut the orifice area or the bone entrance area alone. So this will give a wider diameter at the platform level of the implant, but it doesn't do anything down in the tip of the preparations. So this is basically meant as a last drill, which would require the platform area of the implant or the cervical or the topmost portion of the implant to be placed without any resistance. So these are all countersink drills. So the other components are like you've got a unigrip driver, which will deal with the screws, the different screws which has to go into the implant, or even cover screws and healing abutments and things like that. We'll come into that later. Then you have an adapter. This is a machine-driven adapter for implant, and these are all hand-driven adapters for implant. So these are the things through which you are going to pick out the implant and place it inside the bone and twist it into place. Or this is the one which you can use it along with the machine. I mean, the same, the physio dispenser handpiece. Here you can place it here and pick the implant and place it into the bone. So this is a machine-driven one, and the other one is a hand-driven one. So all these things will be there in any basic kit that is supplied by any company. probably the drill diameter varies, the number of drills varies, the length markings on these drills varies. So this is a basic kit supplied by one of the companies. And so with this, we'll have to place their own implants because the diameter, what is being specified in their countersink and all those things will be the kind of or the size of the implant which they will be supplying. So another company with a different drill, different diameter will be supplying you another another diameter implants also. So these are the basic things. So now to have this class being rolled, we have decided a condition wherein you can see a clinical condition here, which is having one of the upper right quadrant with an edentulous space. So that is a premolar area wherein you have to place an implant. So if you see that area, now what is the kind of planning that you need to do? Whether this area is suitable for implant or not is what we are going to deal first. So let's measure that area. So measuring that area, the best way of measuring that area is by making a model and then measure it out from this, because measuring lengthwise and the width of the available area is not an easy process to do it within the mouth. So make a model like this and measure it inside here. So you can measure it the length of the edentulous span directly with a scale or even with a graduated probe. So you can measure the available length over here and the available width also. So once you get an idea regarding the length and the width, you will come into the kind of implant that you would require to place here. The third dimension other than length and the diameter is here what we require is what is the available bone height. What I mean when I mean to say the available bone height, what I mean to say is how much could be the length of the implant that is to be placed here. So the diameter can be decided from the length of the edentulous area and the width of the edentulous area. And the length of the implant is to be decided by the probable anatomical landmark, which is going to come in between your implant length. So the anatomical landmark that's going to come here between the crest and your implant length is definitely the sinus floor. So if you have a sinus floor there, which is 10 millimeter on top from the crest of the bone, this can be measured only through an X-ray. So let's see an X-ray of that area. So see here. So in this, what we measure and have seen is the height of the area or the height of the available bone, wherein it ranges from the crest of the alveolar bone to the base of the sinus floor or the nasal floor, whatever is there. And on the right, you can see a CBCT picture of the similar area, which gives a fantastic diagnostic value. Because if you see there, you can see the depth of the bone, the height of the bone at different levels. So in that particular level, which you have marked in the other picture as yellow, if you see there, you can see all those pulp canals of the nearby teeth. And at that level, how much is the available width of the bone, which when you see in the clinical side or on the cast, which was very much encouraging. But when you see in the CBCT, you can see it is much lesser than the one what we thought it could be there. So CBCT gives you a very good picture of that bone area without opening the flap. So this is very much required. So that part is there. So considering all those things, what are the basic things to be noted down? So when you place an implant, it shouldn't be closer to the nearby tooth. You need to have a space of at least 1.5 millimeters away from the nearby tooth. The outer diameter of the implant should be limited to that region. Then again, when you consider the labial, the lingual or the palatal bone, minimum of 1.5 millimeters should be there on the buccal side and 1 millimeter should be left on the lingual or the palatal side. So that means between a tooth and an implant, there should be at least 1.5 millimeters. And around the implant, on the buccal or the lingual side, there should be at least 1 millimeter of bone left behind after you place an implant there. And what about the height? In a sinus floor, you can go and rest the tip of the sinus onto the sinus floor. Can never try to penetrate it. All the sinus lifting procedures and advanced things and all are going to be taught in the convention. So that part is much okay with it. And now regarding the placement of this implant, now according to all these things, considering the length of the dentulous span, the width of the available bone, we have come to a dimension of 4.2 millimeters of implant diameter is suitable for this region. So what I mean to say is when you have selected a diameter of 4.25, that means this area has got another 1 millimeter left of bone left on the buccal and the lingual side, or the palatal and the buccal side. And there is another 1.5 millimeter of bone between the nearby two teeth on both the sides. So this implant can be placed in this site, provided this particular, all these dimensions are properly followed when you place the implant as well. So now, so for that, you need to have a proper positioning of the implant. So when you say 1.5 millimeter away from the tooth, that means the outer diameter of this implant should be 1.5 millimeter away from the nearby tooth. So that means the first drill you're going to place is not 1.5 millimeter away. It has to be 1.5 millimeter away from the tooth, and it has to get again added with the radius of the diameter of this implant also. So it's roughly about 1.5 plus this, since it is 4.2, if I consider it as 5. So 1.5 plus 2.5 millimeter away from the nearby tooth should be your first nick. That nick which you take is done with a drill called lance drill. A lance drill is basically a drill used to penetrate the cortical bone, just the cortical bone, but it can be used for another two purposes. Lance drill can basically be used for deciding the exact position of the implant and even the angulation, because the first drill, the way it is being drilled, the position at which it is drilled is going to be the final decisive factor of the final the implant where it is placed. So once you take a small nick with this particular drill, you can go and take an X-ray with the drill inside. So you'll get to know whether it is directed towards the nearby root, or is it going in the real good direction or the right direction which you have planned and kept. So this drill, we are going to make a small first cut in the bone. So assuming that the flap is being raised in that region, I got a model here. This is the same model which you are going to work on in your hands-on training program on Saturday and Sunday. So this will be a model like this. So what I'm planning to do is this particular lance drill, I am going to do the first osteotomy drilling, which will decide the position of the future implant to be placed here. And also, when I take an X-ray and confirm, I'll get to know the angulation of the future implant. If it is going in a wrong direction, I got a chance to correct it always with the lance drill. But once I've done enough with the lance drill, then I'm totally dedicated, or rather, I cannot move it away from that position to another position. So lance drill position is very, very important. And this particular procedure is very, very clearly dealt. And once it's confirmed regarding the position only, go to the next drill. So let's start with the lance drill as such. So I'm going to place the lance drill into the physio dispenser handpiece. I've placed it in. The drilling speed, I've set it to 1000. It can be anything between 800 to 1500 or even 2000. That depends on the density of the bone, and especially with the manufacturer's inspection also. So all those things have to be considered. But generally, when you talk about it, it is 800 to 900 or maximum 1000 that is required. And a torque of 45. I need some torquing also for the drill to go in the way I want it to go. So that is being done. You have a foot control down here. There's a foot control here. Sorry? Yeah. So with that foot control, I got enough of saline being jetted out, pulsing motion. So I'm going to make the first the incision-like thing. So we call it lance drilling, the first drilling over here. So this is the position which I wanted to drill inside. I placed it there. I'm going to place it firmly onto that bone area. The flap is being raised, assuming it's raised. I'm going to place it in this position. And with the whole angulation, I'm going to drill the first drill. A very small drilling which I have done. It has not gone much beyond it. Now I've taken it out. And then I'm going to take out the drill from the handpiece, place it back in this position where I've done the drilling. So that means I've done a drilling to such a level that it can be positioned in it. And of course, now I'm going to take an X-ray of this particular position, just to confirm whether this drilling is going in the right direction. Which I have planned. For example, whether it is in the right position and is the drill going in a wrong angulation or not is very well to be. It has to be definitely assessed whether it is going in the right direction, it's going in the wrong angulation, or have I done it in the wrong position. That has to be assessed then and here. And once I confirm that it is being done well, then you're done with your lance drill. You see here, I have shortlisted a series of drills here, ranging between the lance drill up to the last drill, which I require to place an implant of 4.25 into 10 millimeter size. That means a diameter of 4.25 and a length of 10 millimeters. So the lance drill is already done. Lance drill is over. Now the second drill, this is a very important drill. These are all common drills with any company. This drill is called a pilot drill. It ranges with normally of 1.8 millimeter diameter, not exactly 2 millimeters. Some company gives the first pilot drill at S2 itself. Now, let's not put our head too much into it. Now, it's to be understood that you've got something called a pilot drill. Now, this pilot drill, unlike the lance drill, has got all the markings over it. So it has got the markings of anything that ranges from the kind of length of implant that is being made available by the company. So that means this has got all the markings on it, which will be there even on the last drill that you're going to use it for the most widest diameter which is available in that particular company. So this particular pilot drill is used to determine, or rather to establish, the length of the implant, or rather the depth to which you are going to place the implant. So pilot drill, the lance drill is to determine the position and angulation. Pilot drill is to determine the length of the implant that you are going to place in it, or rather the entire length should be always engaged with your pilot drill. So since I have planned for a length of 10 millimeters, I'll see the markings over here. So that is the end of the silver color, the beginning of this black color is 10 millimeters here. Can you see that? The markings. So the end of this black and the beginning of this white, you can see the beginning of the white is 10 millimeters. So what I need to do is I'm going to follow the same position what I've placed in the lance drill. And now I'm going to deepen it up till the level of 10 millimeters. See, goes 8 millimeters over, 9 over, and it has reached 10. So I stopped at 10 and I've taken it out. So now I've established a length of 10 millimeters. If you want to confirm this length, or if you want to decide whether you can go still more deeper, or any change to be made at this point, you can definitely get it done with an RVG and X-ray. So that can be done at this point of time. So the pilot drill job is also over. Now I've got a series of drills to follow, which is absolutely decided by the dimension of the implant to be placed. So I got so many drills over here. I've got now 2.8, then I got 3, then I got 3.5, then I got 4, then I got something called a countersink drill. Now, this is sequential drilling. This is very much required for the survival of the implant, because implant survival is basically decided by two factors. One thing is the normal temperature of the osteotomy site has to be maintained throughout your procedure. If you go overheating that site, your implant will fail. Second thing is stability. The primary stability of the implant which you have placed. Two key factors that decide the fate of an implant is the heat generated in that region and the primary stability. So to avoid heat generating in that region, you have this saline here, which is refrigerated well. Second thing is you go in for a sequential drilling. A sequential drilling means you drill this particular osteotomy site with multiple drills, which has got small variation in its diameter, so that you won't be overheating that region. So using multiple drills will definitely help in reducing the heat generated in that region. So I got different drills here. So once I've done with the pilot drill, I go with another second drill that is 2.8 millimeters, fixing onto the handpiece. The same area I'll go. So since I have done with the 2 millimeters there, now it is so easy to go with the 2.8. I just go dip it down. I go down and stop at exactly 10 mm and comes out. Finished. That drill is done. Go for the next diameter, that is 3 millimeters. Go for 3 millimeters. Again, the depth is already predetermined. Goes down and comes up. Finished. Then go for 3.5. Take it out. Then comes the final drill in the series, that is 4 millimeters. Since you have to place 4.25 diameter implant, 4 millimeter is going to be the final drill in this particular sequence. The reason is next drill in this particular sequence is 5.10, which will be making the osteotomy site much wider in diameter, wherein the 4.25 will not fit it. So the final drill in this particular sequence is going to be 4 millimeters, and I'm going to drill it. The final drill, the 4 millimeter one into there, goes in, 8 up, 9 up, 10 up, finished, and comes out. Now, this particular site is right now having a diameter of 4 millimeters, not the one in the front, the one at the back. It has got a 4 millimeter diameter, and now I have to place a 4.25 diameter implant. So will it go inside this is to be decided by the density of the bone, whether I'm going to over tighten it, because over tighten will definitely make the bone condense too much and cause bone necrosis. So that should not be there. Primary stability or the tightness has to be there, but it should not be over tightened. So we have got another drill called countersink drill, which will be having only the cervical area having a cutting edge. The other one is non-cutting side. So I'm going to place a countersink drill of 4.25 millimeter diameter. See here. This has got a 4.25 millimeter diameter. So that will just expand the osteotomy, top portion of the osteotomy site. Can you see? It's not engaged anywhere here. Now it's going to be engaged only in the cervical area or the top portion. Finished. So now, if you see the osteotomy site, the site is exactly 4.25 millimeter diameter at the topmost portion, and down it will be 4 millimeter in diameter. So to be more precise, 5 millimeters from the crest till the down portion will be 5 millimeters, and still down will be 4 millimeter in diameter, because you have got an implant which is root form, not a cylinder shape. It is a root form. That means it has got a wider diameter at the top in the platform area, and then it narrows down. That's called a root form implant. That's the general the design what every implants have nowadays. Endosseous implant has got all root form implant. So now this site is ready. You've cleaned it up. There should not be any bone specule particles inside the site. Now I'm ready to place the implant. So for that, I need an implant adapter. This implant adapter is meant for carrying the implant of this particular company. So countersink drill goes out. The implant adapter comes in. Now here, there's a change in the torque and the speed. Now the maximum allowed speed for this particular implant placement is 20 to 30 or even 100. So we'll go in for a range of speed that can be within 100. This is maximum 20 to 30 or 50 could be your choice for a different company. And the torque is 45. Because don't compromise on the torque because the implant has to be refitting precisely into the site. So it's not the speed of the machine that matters. It's the torque delivered by the machine. Now you don't need a coolant for this. So it's to be made 0. Now this is the implant in front. These are dummy implants, which you'll be having during your session and hands-on. You'll be having similar implants there of the same company. So I've chosen to train the same company itself. Now here, you've got a top on onto which the vacuum sealed implant is placed. So that portion has got the cover screw inside this. And this has got the implant inside it. Now I'm going to pick the implant with the implant adapter. See here. I picked it and it's coming out. This is the implant. Can you see this? So the implant is out here. So that implant should not be, should not be touching any mucosa, tongue, saliva or anything with that. Directly into the osteotomy site. Place it inside there. Since I've enlarged it a little bit with the countersink drill, it will go and seat it well into the site and then just drive it in. So 45-degree torque is done. So I have to remove the adapter out. So little bit of your implant area is now over on top of the bone area, which is not a desirable one because our planning was to place it in a equicrustal position, or rather in a position where it flushes with the bone. So another 1 millimeter should be going down, which is not possible with this machine driven now because the speed which you have set and the torque which you have set is finished. Now, if you got to go down, you've got another instrument which is not machine driven but hand driven adapter. Something very similar with which you can carry the implant also. Something which is very similar to the machine-driven tip you have here. So you can engage it on to the implant. Okay, so that is being engaged here. Okay, and now you got something called a hand ratchet. This is a hand ratchet. With this, you can engage it here. And then, in a controlled manner, holding it right here, you can tighten it into position. So this hand ratchet is designed in such a way that it will be tightening only to one side. The other side, it will be just a loose movement. So it just tightens to this side and it moves smoothly to the opposite side. And then tighten it. It goes in. See, it goes in. It goes in. It goes in. And now I'm happy to have it placed in the equicrustal position or flushes with the bone area. See. You got it? Finished. Implant is placed. Now that part is over. Now this portion is being left open. Now, as you know, there was a flap over here which you opened and Then you place this implant into the bone. So now this area should not be left open, or the cover area should not be left open. So you got something to cover the cover area, that's called the cover screw. So for the cover screw, this particular company gives the cover screw in this particular pack. So it is there inside here. Take it out. Place it in position, hold it like this, and then tighten it like this. Got it? Tightened it. Finished. Now the flap which you have raised is going to be placed back and sutured. Implant is in position. Finished. Got it? I'll give a small pause in my presentation and I'll go in for any doubts so far, because I'm not going to stop with this placement of implant, because I know people doesn't practice implant not because they don't know how to place implant, but they definitely do it because they don't know what to do after placing implant. How to go about with the processes part of it, it is very less taught in courses as well. Always you see courses being conducted throughout our country, teaching everybody how to place implant, but nobody teaches you what to do after you place an implant in position. So let's finish off this particular aspect first, and open to any discussion or any questions. Any questions? Nothing. Any questions so far? Yeah, it's like it's always an implant is placed into the most favorable position of the bone. Definitely, which area has got maximum bone support is the area which we prefer to place an implant. But definitely, the patient has not come for an implant in his mouth. The patient has come for a tooth in his mouth. So definitely, all this positioning of implant, everything is to be decided or determined from the final processes how the tooth should be inside the mouth. When you finish off this processes part of also, you'll get a better idea regarding it. And now I would prefer you all to listen to different talks going to happen in the 2-day convention. You'll get a fair idea regarding guided implant placement and all those, the implant site development and all those things. So you'll get a better picture of what is the requirement of having the right angulation? How should be the occlusion of that area? The tooth should be, when you tilt an implant and keep, what will happen to the occlusal line, and all those things will be taught to you in detail. So angulation, basically, all these things, the position, the angulation, the diameter, the length, the number of implant, everything is dependent upon the final processes. The kind of processes what you're going to design over it, the kind of force that you need to for that particular area to withstand, all those things decide the angulation. To put it in simple words, every force delivered to the processor should be through the implant, should not be directed away from the long axis of the implant. Try to make it maximum loaded with the transfer of load through the implant. So if you angulate something in this direction and having a bite over here, that means it's not going to take the load of the force through the implant directly to the bone. Instead, this is going to create a marginal bone loss over here. Many factors are definitely to be considered there. What's that? Of course, you have to consider the support of the bone throughout the time the implant is going to be there in the bone. So the bone loss that's going to happen in future is definitely something that is to be considered at the time of placement itself. Because once you place the implant, and if it's going to have a bone loss because of this wrong positioning, the wrong occlusion or anything, now the implant is going to become mobile. So definitely that is something that is to be very much given a prime concern has to be given to that aspect as well. So bone loss that is going to happen in that area. Once you know this is going to cause some bone loss to that area, then either you should avoid that position or you avoid the implant itself. Because implant is not like an FPD that we normally do. Implant is something which doesn't have a periodontal ligament around it to take the load which is being transferred to it. So all the force that is being transferred to the implant through the crown is to be definitely borne by the bone around it. It doesn't have a shock absorptive property from the periodontal ligament side. So direct force to the implant, directly to the bone. And if bone cannot withstand it, there is no repair or anything like that happens in the periodontal ligament during the process of trauma-form occlusion. Trauma-form occlusion on implant will definitely cause bone resorption. No repair. Minimum residual bone height means the available bone that is there for the placement of an implant. So for a sinus, you can go and rest your implant tip on the sinus. Regarding inferior canal, better to place it 1.5 millimeter away from the nerve area. When it comes to mental foramen, very, very dicey condition. Mental foramen is a very tricky area. So avoid it or give a play of 2 millimeters away from it. So if you don't have enough of length because of available bone in that region, go in for increased diameter. If you cannot increase the diameter, go in for increase in the number of implant. So prime choice is to increase the number of implant. Second thing is to increase the diameter. The third choice should be to increase the length. So length, by increasing the length, you're not creating much of an advantage, but increasing the diameter and increasing the number, definitely that is to create a good implant support to the denture that you're going to place on top. So shall we go ahead with the processes part? Shall we? So now, considering this implant is getting osseointegrated, so during our questionnaire session, this particular implant would have got osseointegrated. What I mean to say is, we have already completed 2 to 3 months time. So this particular now osseointegrated with the bone around it. The implant is now osseointegrated to the bone around it. Once it is osseointegrated to the bone, as my guide always says, it is like a rock. Now, this particular implant will stay there, provided no occlusal disharmony is going to be loaded onto this. If anything wrong from the occlusal side happens to this, then the rock will definitely become sand. So now, once this thing is done, now you're going to open up the flap and you're going to enter into the implant cover screw which you have placed the other day. So now there's a cover screw over there. Now that flap is being raised, and now you're going to remove the cover screw from top of the implant. The cover screw is removed. And you can see the implant happily sitting there, flushing with the bone. Hope it should be always like this throughout its life. It should be like this, flushing with the bone. There should not be any bone loss, though some amount of bone loss is permitted. Even to call it 100% success, some amount of bone in the crustal area is exempted, but still, this is how we expect it to be. Now that thing is done. So you have opened up a flap, removed the cover screw from it, and now you got something by name a healing abutment to be placed into the site. So this is a healing abutment. A healing abutment is basically placed inside to create a collar around the implant platform. Around the implant platform. So that means once you place the healing abutment in place, as the name suggests, this is an abutment used during the, or rather that will favor the healing portion of the mucosa around it. See, now this has gone and this is there in the platform where the cover screw was there earlier. So once it's tightened this in this position, now it has got a collar here. Can you see this? Here. So now gingiva is going to form around here like the normal gingival sulcus. Now this is no more called gingiva, it's called a mucosa. So there's going to be a mucosal sulcus here. Exactly like the way you have the gingival sulcus on a normal tooth. So there's a gingival sulcus to be formed around here. The gingiva comes and tightly closes this region. And the gingival sulcus is formed around it. So this forms the gingival sulcus also. So healing abutment is placed there for 7 to 10 days. If you allow it to remain there, it will form nice sulcus in that region. Now, once that is done, you've got a good sulcus. You've got a good mucosal cuff around it. Now it is time to remove it and take the impression. See, now you're going to remove it from there. Healing abutment is done. Now you have got a mucosa which has got a gingival cuff, or rather you call it a mucosal cuff there. Okay. Now with that, you're going to start with the impression. So you presently has got an implant there inside it, and now a gingival cuff around it. Now you're going to record the impression of this particular implant, which is done in two ways. One is a closed tray technique, and the other one is an open tray technique. The one advised universally is to go in for an open tray technique. Closed tray technique is not a universal favorite thing, but there are conditions where the patients cannot have or doesn't have enough of mouth opening, and certain other indications also wherein you are bound to restrict your procedure to a closed tray technique, which I'm going to explain first, which is not normally done. You should always go in for the open tray technique. So how is a closed tray technique done? Let's see. So for a closed tray technique, you need to have something called a transfer copings for closed tray. Transfer coping means a duplicate abutment. Something like the crown cut portion of a tooth for FPD. You got something to be kept on top here. That's called an abutment onto which the crown is to be placed in future. So right now you have got a duplicate abutment thing. The one that is going to come over it, you have got a duplicate of it, which is done only to transfer the position of this implant. The impression of this implant is going to be recorded. Now that doesn't mean that you're going to push your impression material into the implant. An implant impression is never taken by pushing the material into the implant, but recording the position of the implant inside the bone. So the implant impression is recorded by in a way wherein you get a proper picture of how the implant is inside the bone. Once you see this entire procedure, you'll understand what I mean by saying so. So having said this, now this is the transfer coping for closed tray technique. These are the things required. You've got an abutment which is serrated. Then you've got a plastic material over here that is to be snapped into it. Then you've got a screw, a connecting screw. Now this connecting screw and this portion is to be fixed first onto the implant inside the patient's mouth. So now you have removed the cover screw, you have placed a healing abutment. Now, after 7 to 10 days, you have removed the healing abutment. Now you are going to place the transfer coping for closed tray into its position. So that is to be placed in position first. That's placed in position. Okay, it's fitting well into the bone. Now the screw for that is to be fixed. So this screw, all these screw, this screw, the cover screw, everything is being carried with the same unigrip driver. So that unigrip driver, with that, you place it into the transfer coping and tighten it. So that it goes and tightens. So that is there in position. Now, you're going to snap this particular plastic material that comes along with this transfer coping for closed tray into it, and you can hear a small sound, click sound. It went and sat properly there. So that is very well seated in position. Ensure that it is well seated in position. Now, you're going to take a impression of this. Now, this will not move from this region. It's properly snapped inside. There's a proper groove which will secure the position. Now, you're going to take the impression of this particular plastic material and do it. So now we got the soft body here. The soft body required for an implant impression is very, very little. A little bit of soft body material is required. That is to fill the cervical area. Majority of the material that we require is the hard body stuff. Yeah. So now you got a tray here. This is fitting well. If it had a little bit deeper flange, larger flange, it would have been better also. Now, once it is ready, you place a little bit of your soft body in the cervical region. That's enough. Throughout the cervical area, you placed it. That's enough. Little bit is enough. The hard body is ready. Yeah. Yes, get it over here. Place it on this. So you have done an impression, something very similar to the impression of a crown preparation, an FPD or a single crown or whatever it is. The same kind of impression what you record otherwise. No much complication in this. Only thing is the components which you have used here is probably not the normal ones what we see otherwise. They are all the implant components. So you had the transfer coping inside. Then you had a screw which was tightened the transfer coping into the underneath implant. Then you placed a plastic component over this. Then the normal impression with your soft body and your hard body. So that is done, and you're waiting for that to set. Any doubts so far? You can ask. No doubts. Nothing. Okay. So let's open it. So now that impression is done. Now I've taken it out. So now what you see here is an impression which has got the plastic component inside there. You see here, the plastic component is inside the impression material and the transfer coping is still there in the cast. So that is the plastic component is secured inside the impression right now. And you have the transfer coping, which is actually screwed onto the implant is still there here. Okay, now that is there in the impression part. And now when you transfer it to the lab, we have to give this particular duplicate abutment. Got to remove it from the implant, take it out. The screw is out here. And the transfer coping is in your hand. Okay, so that has come out. This is also there out. And now this particular implant right now, as you guess, will be again secured with a cover screw out there. So you'll place the cover screw back in that position, sorry, we can go in for the healing abutment. We'll go in for healing abutment back in position. So after the impression, the implant is going to have the healing abutment back in position. And this particular thing, along with the transfer coping and the screw and one more component, is to be sent to the lab. And that component is called a duplicate implant. That is called, otherwise called as an analog. This is called an analog, or this is duplicate implant. So this particular thing is to be sent along with this thing to the laboratory. So what they do with this thing is, now once they get the cast, definitely, of course, all these procedures will be taught to you by one of the best labs in Kerala or India or even the world. Dencare Dental Lab is going to give you the entire details of how they're going to make a model out of the impression which you have sent to them. So now what they're going to do is, I'll just give you an outline of what they'll be doing with it. They'll be placing the analog onto the transfer coping which you have sent them. So they will be placing an analog onto this transfer coping which you have sent them. So that's going to make it one piece analog plus duplicate abutment, transfer coping plus analog. They're going to make it into a single piece. And now they are going to put it back into the position of the plastic material which you have the other time when you took an impression, the plastic position, they are going to exactly create it there. So now the analog is outside, projecting outside the impression material, and the transfer coping is inside in the plastic material there. It was the otherwise on a cast or on the model which you planned it or which you were getting trained, it was the opposite way. The plastic was outside and the implant was inside. Here the duplicate implant is outside and the plastic portion is inside. You got it? Now that's the reason why it's called an impression, the negative aspect of it. Now, once they pour the cast over here, what will happen? Definitely this analog will be inside the cast. Am I right? Once they pour the impression, the model into this impression, this analog will go inside the cast material. So it will become exactly like this. If this is a cast, they will be having the analog inside. And they will be having the transfer coping projecting out. And the plastic material above it. Am I right? Yes. Above it will be this impression material. So that impression material will be sent back to you once it is done. And so now that impression coping, that is the transfer coping, everything will be given back to you. This thing, after the entire use of this laboratory, this analog will also be returned to you. So you will get back this part, you will get back this analog part once the whole process is over. Once you have finished with the implant and the crown processes, the whole thing will be given back to you. This plastic thing, it's better you don't reuse it much, because that will definitely take away the accuracy of the impression which you are taking. So now the duplicate implant is inside the cast with the lab people. Now they are going to fabricate the further things, the trials, the final processes, everything is done on this. right? Now, before you go into the next step of it, I'll show you the open tray technique, or rather the technique which is universally done or the right way to record the implant impression. So moving on to the open tray technique, things what we require for open tray technique is this. Another kind of transfer coping and long screw. A long screw and a transfer coping. That is required. Instead of the plastic thing and the other one, you have got these two things here. So once you yeah. Yeah. So you have this long screw and another design transfer coping. You see here, this has got a better grip compared to the other one. So same way, now you're going to place it onto the implant here. That will be placed position. Seated well in position. Then you're going to place not that short screw in position, but a long screw in position. At least few of you would have noticed the height required for this entire process inside the patient's mouth. See this? You need to have a long screw on top of the transfer coping, and then definitely a unigrip driver that has to be inserted definitely on top of it, something very not a normal mouth opening required, but believe me, this much of mouth opening is there in most of the oral cavity. So that's the reason why it is designed in this way. Now you've got a short short unigrip driver also, which will definitely support uh, uh, somebody who has got limited mouth opening. So it will come only to the side. That's also there. Shorter unigrip drivers are also there. So once a longer one means up to this much, and it's not an abnormal thing, but it is something very usually being we don't come across much of a difficulty. But if at all it happens, then definitely, as I said earlier, you'll have to switch on to the closed tray technique. Okay, now that is being placed here. Now for this, now you have the transfer coping and the long screw in position. Now, when you take an impression, you are not going to take a direct impression like this as the way you did in the closed tray technique. And that's the reason why this is called an open tray technique, because now you're going to make an opening in this tray. This tray is going to be perforated a little bit exactly in the position where this particular long screw is going to come. So it is somewhere here. Now in that region, I'm going to make a small hole. Now you opened the tray. Now that is positioned. Can you see this? It's totally different from the closed tray technique. Now this is an open tray technique of impression making. Okay, so it is fitting well inside or through the abutment, through the long screw. You can see the long screw outside here, projecting outside the tray. Now the same kind of impression, fixing and all those things are done here. The same thing, a very little of your soft body is required. Only to fill that cervical region. That is to get the impression of the sulcus. Yeah, the material is filled here, and the entire thing is pressed down. And the long screw comes outside through the hole. You secured its position. Make sure that the material is projecting enough through the holes, or else it will stay back there. Very well fixed. Waiting for it to settle down. Any doubts? Any doubts in the message? No. Lovely interactive session. Okay. So thing is getting settled there. So now you understand, in contrary to the closed tray technique, you have placed a transfer coping there on the implant. Then you have secured it with a long screw, not the short screw which went inside the transfer coping for the closed tray technique. For this open tray technique, it's a long screw which projects outside. If you make a hole and give, it projects outside. So you made a hole, so that thing is projecting outside. So you have the screw tip or the head of the screw projecting outside the tray. And now once the thing is set, the material is set, now you got to remove the long screw from the transfer coping. There will be always some impression material inside the notch here. So that is to be cleaned, removed. Then the long screw is to be removed. See, it comes out. Okay. So now you can guess what's going to happen once you remove this. You have the transfer coping inside the impression, and the implant is as such inside the bone. Same thing, what we are going to do is send back the patient at this point of time with the transfer coping, and then this is to be sent to the laboratory. Now, once you send this particular thing to the laboratory, what you're going to send along with it is a long screw. And again, the same or the similar kind of the analog. So an analog is a duplicate implant, and transfer coping is a duplicate abutment. So an analog is to be sent along with that. So analog is to be sent along with that. Along with that, a long screw. So these two things are to be sent along with the impression, which contains the transfer coping inside it. What they will be doing to it, just have a look. They'll be placing this long screw again into the same position. Got it? And then they'll be fixing the analog on top of it. How exactly they do it in laboratory, all those illustrated video, everything will be shown to you on day 11, that is on Sunday, by Dr. Lina Beni. She is the executive, she's a dentist in Dent Dental Lab. She'll be showing you the entire process, which I have shown it in a not in a proper manner. They'll be having their own ways to do it in the laboratory, which we don't generally do it at all. We don't do this pouring of this impression in our dental clinic. So that is being done. And now once you pour this cast into the model into this impression, this analog is going to go inside the cast. So that definitely says you will be having a duplicate mouth, or rather a duplicate jaw, with the implant inside for them to work their laboratory procedures. So that is an open tray. Once the things are being done, this analog and the transfer coping and the long screw will be returned back to you. So that makes your job as a doctor complete with the impression. Now, once they have the cast with them, they'll pour it into it. And now what they'll be doing is they'll be asking us to confirm the position of the implant, or rather they'll be asking you to confirm whether your impression was right or wrong. Now, when you say your impression was right or wrong, sum up whatever we have seen during this impression procedure. If you carefully watch it, if you carefully analyze it, we were actually recording the impression of the position of implant inside the patient's mouth. The position of the implant, not the shape of the implant, not the other things like the margins or anything that we have in the FPD, what we do here. It's basically the position of the implant. For open tray technique, we require different impression trays for each patient. We definitely require different position of that hole. You can use this same tray to make another impression. If at all this hole doesn't bother much to the position of the next impression, you can reuse this tray as well. If it is there somewhere nearby or somewhere in the same position, enlarge this hole and use it. If you have multiple implants, I think that's the question. Okay, if you've got multiple implants, make multiple holes. So there will be multiple transfer copings, multiple long screws, and multiple holes, and the same impression. So this impression will be having multiple impression copings inside it, which will be having multiple analogs over it. And once you have the final cast, you will have multiple implants onto your cast also. This can be reused. Only thing is, this holes should not interfere in your impression procedures. Like too many holes, and then generally the impression might be not. It will be flexible, or impression may not be accurate, because you cannot apply enough of pressure if you have got too many holes in it. Because the basic shape of the tray should be favorable for an impression recording. Yeah. So now, once the cast is ready with the laboratory people, now what they do is, now they got to confirm the position of the implant. As I already said, what we have done is not, we have not recorded the shape of the implant or anything. It's the position of implant inside the mouth that is being transferred to the cast in the laboratory. So they have the cast with them. Now they got to confirm whether the position of the implant, which is there in the patient's mouth, is exactly replicated in the cast or not. For that, they've got a procedure called jig trial. Now this is, and if you can see in the other view, that is a jig trial being supplied to the dentist to see whether that particular red thing, what you see over there, is fitting exactly the same way inside the patient's mouth. You got it? So this thing is made over the transfer coping which you have sent to them. The similar long screw is there in it. The duplicate abutment, what we call as the transfer coping, is there in it. Now they have placed and given you a connection between the transfer coping and the nearby tooth. In whichever shape is right for them, they'll do it. Now, what decides on the shape of this plastic material, again, will be taught to you in detail and in depth in the class on the laboratory procedures, which will be there on 11th of Sunday. I request you all not to miss those classes, not just that class, not to miss any of the classes, including the banquet we have in store for you. So don't miss out even a minute of it. And its humble request to you all at this point of time is, if at all you have a fair good idea on the implant drilling and placing, which I have shown you right now, kindly stay back in the hall and listen to the lectures. But don't worry about it. We are recording, video recording all the lectures, and in a very good quality. And that will be made available for you through YouTube. So don't worry about any of these sessions being missed, but having it learned by the real stars of the implants in the nation. So that will be always a different technique, I mean, a different way of learning than learning it from the YouTube. So if you see here, that cast is being sent to us with the plastic thing on it. Now you're going to transfer it to the mouth and see whether it is fitting exactly the way it fits in the cast. So if at all it fits in the model in this way, and the plastic thing is in the proper position onto the nearby canine, it should sit exactly in the same position in the mouth as well. See, it fits exactly in the same position in the mouth. Now, what does that indicate? Now, that indicates the impression which you have recorded is perfect, and the implant is in the same position the way it is inside the mouth. So that is being clearly recorded, and the jig trial is successful. And now this is the important step. Take an X-ray and see. Take a radiograph of that area during your jig trial and make sure your transfer coping is fitting really good or well into the implant, because there can be accidental ways of keeping the transfer coping, and you feel the jig trial is okay. But jig trial, for a good, really good jig trial, you don't need a screw on top of it to seat in position. If you can see the transfer coping with the plastic, the red color thing on top of it, fitting onto the nearby tooth, even without fixing a long screw onto it and tighten it, that shows it's perfect or accurate. But always make sure that you take a radiograph and confirm the position of it, and it is well done. So now you remove the jig trial and send it back to the lab, finished. Now there is no more job for that transfer coping anymore. Now they will construct the second thing on it, that is the crown. The crown could be a cemented crown or a screw retained restoration. Again, I don't want to spend much time over that particular topic again, because that is going to be dealt in detail. What are the indications for making this crown cemented or screw retained? What are the definite indications of a screw retained crowns, and where exactly you will have to restrict yourself to cemented crown? When I say why to restrict, because Carl Misch's textbook, if you go through that, they clearly says cemented is a compromise. Screw retained is the right way of restoring the processes. Now, I'm not here to debate on it, but that is what the textbook says. So what you see over here is a screw retained restoration. You will be having models in the conference, which you can have a feel of this jig trial, and also the cemented and screw retained restorations will be made available there in the venue. You all can go and have a feel of how that is to be placed, how this is to be done, all those things, all these impression techniques. You can do it as a hands-on in one or two stalls which will be kept there. Now, don't worry about all those things. If you cannot go and do any of these procedures during the speculated time, if at all, by some reason you could not do it well, now believe the organizers of All About Implants, we are here not to send you off without accomplishing the aim what we people have. We are here to popularize the procedure of implants, not for any other commercial reason, for the simple reason that we are majority of the members of SPIK and COPS are all academicians. So we are all here to teach you the exact way how implant is to be practiced, and by no means nobody is spared out of the delegates who are going to attend this program. You all will be taught all these things in the venue once again. But as I told you in the beginning, this is to make you people probably prime into the implantology field, and as what I understand, the entire the crew of this particular project, the convention is working hard to make this more of a delegate-centric conference, not an organizer-centric conference. So all these things will be taught to you once again during the convention by better teachers and better trainers. So we all will be there. In case by any chance you miss out any of the sessions, if you want to have a hands-on, please come over. All these things will be made available and we all will be there in the venue as well. So extending this this particular program on to welcoming you all to this conference as well. So we have conducted a pre-conference thinking that you all are well primed into the process of learning implantology. So we are here open to any questions. Any doubts, please ask. Now you can see the final process in position also of that particular case which we started off. That's the screw retain restoration. So you have this hole there, which you close it with glass ionomer or glass ionomer restoration, restorative material. So you place a cotton inside it, which will secure the notch of the screw. Cover screw and healing screw. Probably the question would be how many days should the healing screw be there in the position? 7 to 10 days is the ideal time for the gingival sulcus to form around it. So give it a time of anything between 7 to 10 days time. Now there are situations wherein we record an impression even at the time of implant exposure itself, because this implantology science doesn't have any particular syllabus or rather any particular single line of its teaching or understanding. Anybody who practice implant very well will definitely agree with me. They have got their own ways of implantology practice. So I can always suggest 7 days time. Anything more?
Session recorded.
Yeah, this session is definitely recorded. And the link also shall be sent to you. Not just you, it will come in the group as well. Only I wanted to restrict it to people who have not into implants, so that they will all learn implants. It's not that I'm running anything commercially related to implant as such. I want everybody to be into implantology practice. Immediate loading is something which is a big debate since a long time. So now immediate loading is a term which means you load an implant immediately after placing it. Immediate implant is another thing. Immediate implant means you plant an implant into an extraction socket. Immediate loading means you load an implant or place a temporary prosthesis or an interim prosthesis on an implant immediately after you implant it in position. So there are different schools of thought which says that should not be done. There are definitely a lot of scientific data available in the literature which says nothing wrong in loading it immediately, and it is equally good as loading it delayed. So if you ask me for a definite answer to this question, which says, what is that? No, I think that question has to be clarified a little bit, because once you're placing a crown over it, immediately loading it, then it is not cover screw, neither cover screw, not healing abutment. It's going to be a real abutment on top of it and a crown placed over it. When you're loading it, when you're loading an implant, that means it is not a cover screw, not even a healing abutment over it, but a real abutment and a crown over it. Hope it's clear. Osseointegration is totally dependent upon the bone which you have placed an implant. So a healing time ranges between 2 to 3 months time, or if at all, this is an immediate implant which you have placed. That is, if you have placed an implant into an extraction socket, then it takes a longer time. So the healing period is again an area-centric question, but you can always call it as a period, or rather you can always say it is somewhere between 2 to 6 months time, depending upon the density of the bone, the kind of the person's other systemic condition and all those things. But to put it in shorter words, it ranges between 2 to 6 months time. Yeah, that is dependent upon the osseointegration, right? Once it is osseointegrated, it's ready for loading. But then the question arises, then what happens during an immediate loading? What will happen to the process of osseointegration, what you've been learning? And why do people say you can immediately load to it? Let me make it clear to you. I personally believe in delayed loading, not immediate loading. Now, don't ask me why. Probably I would have had a lot of failures that would have made me think in these terms. Could be. So I believe in waiting till the osseointegration is complete, because I belong to a group of faculty, or rather belong to a group of teachers who believe osseointegration is the process that retains implant in position. So let it osseointegrate, then do it. Now, there could be definitely a difference in opinion. We have a session itself on immediate loading, and I think 2 people are going to speak on this particular topic. So listen to them. They've got their own reasons why immediate loading is done by them. But probably I had a lot of failures on loading it immediately in that hurry. So I prefer to stay back for some more time, allow it to osseointegrate, and then probably do it. I may be outdated or mistaken, but still this is what I practice. Guided implant is has got nothing to do with the loading side. Guided implant surgery or guided implant placement is guided placement of implant. So you are getting guided by something, or there is a surgical template which will help you to position and angulate exactly in the area which has got maximum bone support, or decided by the CBCT. So a guided implant surgery is done with a stent, something like a stencil through which you would have been writing in a good handwriting in the childhood days. So you have got a stent through which you will be placing the implant. So this is guided implant surgery is a technique which will help you to position and angulate implant in the right area, which is decided by the CBCT and other planning method. And as you all know, we have got one session on Saturday from 5 p.m. to 8 p.m. totally dedicated to the training of guided implant placement. I just had a call from that person. I could not receive it because I was into this class. So those people are very much enthusiastic in teaching the entire crowd on guided implant placement. Kudos to them. They are called DO implant people. DO implant it is. There is a person, Dr. Lilith V. Anand, that is the chief faculty for them, and then another person, Arun Kumar Ji. They both are coming from Bangalore. They are going to give you a detailed class on guided implant placement, as well as a training session from 5 o'clock to 8 p.m. I know that's a time that's going to encroach into the banquet period, but I don't care. So that is going to be taught to you, and a 81 of us are going to get a chance to place it with within the executives around us. So you'll be having a guided implant placement, so well guided by the masters of it, and all the other delegates are given a chance to watch it, and they all will be around the people who are placing it. So they all will be learning it together. Probably only 81 of them will get a chance to directly place it and probably take back the models home. But you all will be learning what is guided implant placement. Anything else? I think that ends up the session. What is decided? Any more questions? Now, don't worry about asking questions right here. You can ask it in the group as well. And whoever you have seen around sitting here, they all will be there in the venue as well. So if you have got any doubts pertaining to what we spoke right now, definitely you can ask us during the convention period, or through the group, or directly, or any time possible. Whenever you have a doubt, you can definitely contact us. We are very, very happy, always happy to help you out. Yeah. Thank you, one and all. Thank you. So hope to meet you all during the convention. Thank you. And thank you for registering with us and keeping the faith with us. And definitely we are all working hard to keep up to your expectation. Thank you. Finish.